name is Dr. Rachel Cady. I'm an obstetrician gynecologist and I work at Cuyuna Regional Medical Center. So I've been practicing at CRMC for about 16 years. So pelvic pain is very common for women of all ages. And some of the causes of pelvic pain really vary by somebody's age, but it's definitely something that's very common, and majority of women experience some degree of pelvic pain at some part in their life. Again, depending on a woman's age and a little bit with their history, really gives us a guide as far as some of the more leading causes of pelvic pain. And for example, women in their childbearing years, we think more about in general with pelvic pain, is it acute, meaning less than 6 months duration, or chronic, meaning greater than 6 months duration, related at all to their period? Is it more on the outside, meaning an area that you can actually touch on the outside and on your bottom, or is it more deep within the pelvis? Occurring at times of periods or times of intercourse, worse with having a bowel movement, worse with a full bladder. So we think about things such as painful bladder syndrome, interstitial cystitis would be the other term for that, irritable bowel syndrome, endometriosis. We think about vulvar concerns, meaning the vulva being the area in between your legs, essentially from your pubic bone to your tailbone. We think about any history of trauma, primarily after having a baby. We think about different muscular problems, neurologic problems. There's a nerve that comes from our lower spinal cord called the pudendal nerve that gives our pelvic area its nerve supply. And so if there's swelling or injury to that nerve, a lot of times women will come in with pain. And certainly some of the other more acute issues would be more related to things like in childbearing years, things like infection or again, endometriosis. Really a lot of it just depends on the patient's history. Switching gears a little bit, when you have somebody who's menopausal, on average those women are 51 and over. And for those women, a lot of times the issues surrounding chronic pelvic pain can also be neurologic, meaning something from the spinal cord, history of trauma, certainly issues related to pelvic organ prolapse where they might have more relaxation in their pelvic floor. And also, we also commonly will see genitourinary syndrome of menopause. GSM is the term for that. A lot of women refer to that as vaginal dryness, but it's a condition that doesn't just affect the vagina. It affects anything that you can touch in between your legs, where there's thinning of the skin and the underlying kind of stretch, collagen, muscular component, and so the skin is more apt to tear. Women will describe newer, painful intercourse. Sometimes there's even some scarring. We also think about more commonly skin changes in the vulva, not just related to thinning of the skin, but also different vulvar diseases like lichen sclerosis, things where women will have a lot more itching or burning, those kind of issues related to pelvic pain. A woman, as far as counseling them about what to expect when they're coming in for a visit related to pelvic pain, it's really important to understand that a lot of women feel like they're out of control with it. The symptoms have been going on for months, if not years, in some cases decades. So they are understandably anxious, worried, maybe pessimistic about the consult to begin with. So they need to understand first and foremost at the start of their visit that they are in control of the visit, that what they feel comfortable with really determines a large part of how the consult goes. And sometimes it's strictly just getting a history, and because there oftentimes is a big level of anxiety, and that's okay. And so we let the patient really dictate. But it's very helpful before somebody has a consult for pelvic pain, regardless of their age. Sometimes if they can just even have a little bit of a documented history, like what some of their daily symptoms are like, things that are really big triggers for them, what they've notice makes things worse, makes things better, interventions they may have tried. Just again, when you're talking about years and years or even months of having something so awful as pelvic pain, it really helps for me, just to listen to them and to kind of have that narrative discussion. And so sometimes we'll have the patients also fill out some questionnaires as to really try to focus some of the more important aspects of pelvic pain. We always begin the visit just with the patient dressed, and a large portion of it, again, is this history gathering. I'm here to listen to them. I also encourage the patient to bring a notebook, or we'll give them a piece of paper, something that they can take notes on as well. As far as what is done from an exam standpoint, it really depends on, first and foremost, what the patient's comfortable with. I tell all my patients that they're in control of the exam. If something is too painful or too uncomfortable for them, that the exam is stopped immediately. They're in absolute control. And when we are examining for causes of chronic pelvic pain, again, I listed off a whole bunch of different causes, so it's really pretty long list. But it simply is starting outside in, as far as is there an issue with hips, pubic bone, abdomen, back, skin on the outside of the vulvar area, muscle layer underneath the skin, before placing speculums or going right to the vagina, the cervix, uterus, if that's present. It really is layer by layer observation. Sometimes we do a Q-tip kind of pain mapping. Sometimes we're looking at the tissue using a microscope. Again, that's not a painful thing. It really just depends on the patient. But first and foremost, it's history taking with the patient dressed, a narrative, a conversation, and then a pelvic exam to the degree the patient feels comfortable with. Women do not need to just live with this pain. And the important thing is to, again, write down your thoughts, write down your history, and really try to make an effort to call for a consult so we can just get things started, get the ball rolling. I think that sometimes women that have had pain for years or, again, months just feel like there's no other option. Maybe they've been disillusioned by prior appointments or disappointed. And so a lot of times it is a little bit of a journey, but just having somebody that is confident, that really wants to be there for you, wants to listen and be there on your journey is comforting. There's a lot of treatment options. It just really depends on, again, that history primarily, and certainly partially the physical, to just get a general direction where to go. They can call our OB/GYN clinic directly, and that is on our website.